So today I will be co-moderating this session together with Professor Akın, and Akın will do most of the speech. So we'll be talking about the cognitive disorders and about the ADHD and their distinctive diagnosis. So I want to provide you with a short brief. So back in time, the ADHD was defined as a brain or neurological condition. It was like there is something not going well in the brain, like an organic disorder. Afterwards, the hyperactivity was classified in ADHD and non-ADHD type. And after that, we saw that there was a gap, and that within the group with ADHD, there was this thing that couldn't be identified as such, and it was during the time of DSM-4 by Mr. Benjamin White was classified as a different group. And this group is the predictor of the slow cognitive group. And after that, we see this group which can't be classified quite as ADHD, and it was determined as a total different disorder. Also, the studies of Becker and Barclay on this topic indicated somehow that it can be something different. And according to DSM-5, this is not accepted as something different. And according to DSM-5, we have different metrics. And also DSM-5, because there is a lack of evidence, didn't accept that. And for the restrictive subtype, we did some brain imaging and MRIs. And afterwards, when we came to the recent date, I think that in the literature, when I scanned PubMed, there are almost 260 publications, and I think that 10 or 15 of those belong to our group. So when we are looking at the genetics, at the brain mapping, and at the treatment response, we can see this as a distinctive or separate illnesses. In 1997, Peter Jackson claimed that there should be concomitant disorders, there should be a different prognosis, etc. So they decided to classify these as a different illnesses. There were like 8 articles items in order to define this disorder. So most of them are actually matching, and we'll be witnessing all together the future developments. So we really need to have the definition of the slow cognitive tempo, because we know that this group of patients, for them, there is a lower probability to apply to the hospital. And we have a 2-stage evaluation system set by me and Akın. This is how we started to scan those patients, and also Nuran knows this. Also with Professor Vahdet and Mücahit, we worked very hard in order to get the authorizations from the schools, actually from the Ministry of Education. It was very hard. So for now, we are collecting the initial data. We are very excited about that. And after that, we will be publishing in Turkey, of course, uh, a, a study on this cognitive syndrome. And this is something that is going to be made for the first time in the world, because the until now we only had the surveys with the questionnaires like Google Forms or similar forms, or in our clinical trials. Most probably we had something related to ADHD or to the anxiety or depression. So after this intro, I want to invite Mr. Akın Tahıllıoğlu, and after that the discussions will be continued. He is a very successful clinician. Hello to all of you. We are here at the 15th International Congress on Psychopharmacology, and I'm very happy of being here. So as Professor Eyüp mentioned, we have this slow cognitive tempo, and it became very interesting. It's a clinical thing. Do you have any child psychiatrist or adult psychiatrist? Can I see? So we have more like child psychiatrist. I am a specialist doctor. I'm working in Izmir as a child psychiatrist. So we have this cognitive disengagement syndrome, means having hallucination, means difficulty in staying awake. And also it is indicated as a disorder of cognitive properties. So this is the history. It's very old, in 18th, and it was defined by Alexander Crichton, and it was defined for the asocial persons. And if we have looking to the history, according to DSM-2, ADHD is a symptom for hyperactivity, but after that, DSM-3 classified into, and after that a subgrouping was made, and we have DSM-4 with three subtypes. And of course, those routine changes, they happen a lot. And the symptom clusters were investigated further. And after that, we have the sluggish cognitive tempo. And for the first time, it was used as a part of ADHD. So we have a factor analysis, and according to DSM-3 system, ADHD plus hyperactivity subject and minus hyperactivity subjects have been evaluated with scales, and three factors were mentioned, like sluggish tempo. This is the trial of Skansgard, and it indicates two different groups of patients. And in this group, it has been seen as more. And the different persons, they obtain three different clusters. A lack of attention, relentlessness in the capabilities of being organized. We have sluggish cognitive tempo, and also we have ADHD, we have hyperactivity, impulsivity, and also we have the group with the lack of attention and relentlessness of having organizational skills. We have three different clusters. We have ADHD minus hyperactivity, and 75% of this is accounting for the third group with ADHD plus hyperactivity. So here we can see this factor. And after that, it was claimed that it's a part of the ADHD. After that, it was understood that it is different, and it wasn't included in the DSM as a psychiatric disorder, and it was claimed that it was totally different from ADHD, and ADHD restrictive type is recommended for DSM-5, and also it is claimed that it has similar characteristic with SCT, but it's not included in the DSM-5. Here we have the decreasing ADHD phenotypic heterogeneity, and in order to decrease that, the study made by Professor Eyüp, the genetical, neuropsychological, and neurobiological properties of ADHD were looked at, and they saw that the alleles of VRD47 were more frequent, and also there is more activation at the temporal occipital lobe. So this is classified as a restrictive disorder, and it can go in parallel with the ADHD. So is this a disorder or a structure? The previous trials indicated this as a subtype of CST, and it is claimed that it can be an independent disorder. But some of the authors claims that it should be considered as a transdiagnostic construct, and also Barclay in their trials he wanted to identify us as concentration deficit disorder or other types of deficit disorders. And also in 2020, it was the cognitive disengagement syndrome was accepted. So why this term? Because the sluggish term is a foreign term, and it's a little bit awkward. So we are talking about cognitive disengagement syndrome. So it is identified as a different syndrome, but we still don't know if this is a disorder or not. Is a transdiagnostic or is an independent disorder? So what are the symptoms of CDS? Imagination, having difficulty in staying awake, confusion, looking with empty eyes, can give attention to surroundings. They are not energetic, they are slow. And it's hard for those people to understand what they have been explained, and they get lost in thoughts, in their own thoughts. So the topic in this meeting is the distinctive diagnostic with ADHD. And we can see the CST symptoms in here, and also the ADHD. And also in the 39% of that we can see the CST, and also we have subjects with pure uh, SCT but non-ADHD, and the rate is 30%. And it was observed a 10% rate for that. When we are talking about distinguishing those disorders, we have two different symptoms. We have the sluggish, and especially when it is combined with the ADHD, we see a more correlation in here. And also in this trial of Barclay, 59% of CDS diagnosis also includes the ADHD, and the 39% of the subjects in the subtype of ADHD, they are matching with the SDS. And this relation is like anxiety and depression, and they have matching characteristics. They are different but are interrelated. So we can talk about the similarity of the relations. Here we have the demographic profile of the CDS. No significant difference in the age distribution, but some of the studies indicated that CDS plus ADHD indicates a bigger and older age according to ADHD, and also there is a correlation. No differences, no significant differences between the sexes. But in some of the studies, it was noted that the girls are more prominent to CDS when compared to the males. And there is also no significant difference between different ethnicity and between the low parent educational level and low socioeconomical level.
Derken bizim çalışmalarımızda özellikle düşük anne yaşıyla CDS ilişkili bulundu. Bununla ilgili yayınlarımız da çıktı. Ama literatürde henüz hani bu noktada henüz net bir şey söylemek mümkün değil ama düşük anne yaşında dikkatinize çekmek isterim. Aile yapısı açısından da farklı.
Younger maternal age. So let's have a look at the comorbidity patterns. So in the clinical evaluations, it was seen that the CDS subjects have a temperament which is more anxious. And again, with the CDS subjects, we have the retrospective personality. It's difficult for them to express their needs, and also they are shy, and sometimes they can fall back on catching the social tips. And also recent study indicate that the kids with CDs are more social and shy when compared to, and less interested, of course, when compared to non-CDS children. Like I was saying, the internalizing symptoms are more predominant, and the externalizing symptoms are observed like fewer. And also the substance abuse can be seen. So what are the difference in terms of comorbidity pattern between CST and ADHD? So with the ADHD, we see both destructive behavioral patterns and internalizing, while with the STC, we also can see externalizing behavioral patterns. Talking about the impairment and the CDS, also in the ADHD group, we saw the highest and also the lowest in the controls. So when compared to the control groups, there is a little more impairment, but of course it's less than those in the ADHD group. So in the case of ADHD, the impairment appears more severe during the home or school environment, especially in the subtypes. It's more predominant. And with the CDS, the impairment is observed more frequently in the social environment. We can say that it has a higher severity, and also it is related to with different personality patterns. The ADHD is more sensitive against the rewarding mechanisms, and they are more prone to take the risk. But with the CDS, they are more sensitive against punishments. They are shy and they have fears. And also we have some functionalities, academic functionalities. And I wanted to present you this similarity pattern. With the CDS, we can see lower success in the mathematics and lower capabilities of in the literary capacities. Here, the studies conducted indicated that the CDS can be correlated with the lower functionality performance, lower learning, and slower processing speed. According to the observations of the educators, only the CDSC kids, when compared to the HDHD kids, it is indicated that for them the academical learning is harder, is more difficult.
CDS bulgularına göre daha fazla akademik zorluk yaşama ilişkinde çıkmış. Yani her iki klinikalitede de
So in the both clinicalities, there are some academic difficulties, and there is a risk factor for that. We have a new study, and we have 142 subjects between the age of 8 and 15. We have the ADHD group and the ADHD plus CDS group, and they were compared in terms of the CDS symptoms. We had 47% in the first and 50% in the second one. Here we took the independent and dependent variable, and we had very high numbers. We also took into consideration different factors like educational level, socioeconomical level, and the of the parents. And we see that the CDS score was significantly lower than the HDHD score. Ne yapalım?
Zeka, bazı ilişkili demografik faktörler kontrol edildiğinde de bu ilişki.
So, when it comes to the relation between the CDC and ADHD, especially daydreaming symptoms, were posed as a predictive factor in terms of difficulty of learning. And also the cognitive deficits are important in terms of visual perception, inattention. And when IQ is controlled, we can see that CDS have a larger spatial variety. And I want to mention about the working memory. So the working memory is low with the CDS. Also, the studies carried out on dyslexia indicated something similar. So there is this question if we can talk about the common psychopathological condition underlying. Here we have the measurement tools for the CDS. We have the Berkeley Children Attention Questionnaire. We have CST, CBCL. We have evaluation scale and self-evaluation scales too. The Berkeley Children Attention Questionnaire survey is the most used one. We need to have like 3 or 4 points. It has 2 different types for sluggish and daydreaming. And there is another checklist used by most of the child psychiatrists. We have the child behavior checklist. Here you can see the confusion, daydreaming, looking, emptying, slow movement, lack of energy. So those are articles or items measuring the CST, the 101 and 102 numbered articles. And also we have different scales. We have the children. Ergen neydi ya? Ergen ne ya? We have the children adolescent a behavioral scale. It is a scale made by Professor Hagan, and also it includes 16 items. And if you get an average after above 2.1, this means that you are scored as low risk for CTS. You can also ask Professor Akın about this scale. And also we have the 4 Likert type scale. It has 14 items. And we have self-statement questionnaire of Professor Nuran. We have scores between 1 and 5, and a score of 3 or higher indicates CTS. Also, we have the adult CST scale. Maybe it can be enough to know about this one. And it is a very important scale because there aren't enough trials and studies on adults. So talking about the distinctive diagnosis of the CDS in terms of genetical imaging. Here we have performance functions. And also the reason of the cognitive and behavioral issues known with the ADHD is because of the lack of the connection in the prefrontal lobe. And also in the study of Barclay, the performing functions in case of the CDS are less impacted when compared with the ADHD. And also at the kids and adolescents with the ADHD, the lack of organization was more predominant. However, another study, especially in terms of emotional control, working memory, planning, organizational skills, and some deficiencies have been identified. So the issue with the ADHD is the sustained attention, and the issue with the SDS is the engaging attention.
Zihnimizde kavramsallaştırmayı artıracaktır. Ayrıca CDS'de erken bilgi işleme ve seçici
And also with the CDS, the early information processing. What about the processing speed? Which is expected to be slower, which is also expected to have a longer reaction time. This is a common pattern of the CDS. Again, here we have the daydreaming, confusion, and the slowing behavioral patterns. But the psychomotor speed and the reaction times are not different from the healthy controls. And also with the higher CDS levels, we can see slower or sluggish cognitive functions. So what cognitive processes are sluggish in the sluggish cognitive tempo? The slow acting working memory, and also the inhibition systems are seen to be quicker. But not everything is slow. So we are not claiming something like that. So is CDS a vigilance disorder? And again, Professor Eyüp has a study on this topic. And here we have a shifting attention test between the CDS and ADHD. And also, in case of the subjects with the CDS comorbidity, they observed even higher disruptions. So specifically, we can say that discontinuity of this annotation is something innate to the CDS and can be classified as a precursor of that. Talking about the etiological factors, especially when we are comparing the CDS with the ADHD, the genetical transmission is not as higher as in the first one, and the genetical factors are fewer in the case of CDS. Also, low IQ and low academical success, and also we can see that in the subjects with acute leukemia, it can be more relevant. There can be like higher CDS levels. And also there was a twin study among inattention, hyperactivity, impulsivity, and sluggish cognitive tempo problems. And it was mention that CDS is the dimension including the less similarity. 398 twin pairs were included.
And here again, according to a study performed by Dr. Hilmi Polat, in which we are also involved, regarding the genotyping of GDC, four groups were taken, including also the control group. In only the GDC and control group, there was there there was no significant difference, and except for the psychomotor speed, performance, and cognition mistakes. And here, in that one gene, with this the genotyping of the RD4 gene may differentiate symptoms of attention, and in the RD4 there were 4 R homozygotes. It was the most common spread. Only in CTC group, it had the highest 7R frequency. And turning back to the original study about the restrictive TNT, it is seen that the L7 alerts are more frequent, so we can speak about the significant similarity. When we look to the neuroimaging on MBT, these are very common, but the situation in the CDS is not so common. The first neuroimaging study was made in CDS, and here are the CDS symptoms. There is hypoactivation in the left superior parietal lobe, and the attention deficit symptoms manifested as hyperactivation in the thalamus, and this area is superior parietal lobe, which is relevant to the general attention. And according to another study conducted in 2019, the correlation between the CDS symptoms and brain activities, no meaningful difference was detected, but there was anatomic functional differences in the green core. The certain areas of the frontal lobe are detected according to abnormal functions, and in the study performed by the professors, the determination of DB controls were made, and especially compared to the controls in GDS, it is more abnormal. And yes, here the neurobiological differences were not investigated relatively, and inclusion of the other factors could give more consistent results, they say. And also fMRI was used in the no-go task, In the DB plus CDs, more activation was determined. However, in the DB plus CDs, which is a sub a part of the attention deficit disorder, no difference was detected. Here, when you give an attention requiring task, the posterior brain parts get more activated in those with CDC, and this is it so it can be compensated according to the interpretation. And finally, I brought here two cases, especially in the cases with CDC, the distinguishing diagnosis process, what can be performed in the treatment process. We can discuss about this. So our case is 8 years old, living in city center with father family, no siblings. Father is 40 years old, high school graduate, worker. Mother is working also. The reason for application is low success academically and lack of attention. And 8 years old in second class, learned reading and writing lately. He was a calm child, but he didn't have much friends during the nursery home, kindergarten. He didn't have any mobility or behavioral problems. The child was not giving answer to the questions confidently. Yes, the whole things, the pausings, going to the school empty, coming empty, daydreaming, etc. If you hear this, you can be suspicious about CDS. The story of the disease is deepened, and uh, the mother observes her child as immobile, as very calm, as giving the replies lately, and being observed as a slow working, slow learner, etc. And when I ask, the mother confirms, yes, this is how my child is, she says. And the child has a normal medical story, the family story, everything is ordinary. In the mental health examination, there is eye contact, everything is normal, and there is no behavioral problem, there is energy at moderate level, and the child answers the questions in a little bit delayed manner.
O yüzden böyle geç cevaplar. Sanki onu yaşıyormuş gibi hissediyorum ben
The child
o andan
gives the
böyle.
answers
Davranma sorunu yok.
uh,
Hafif böyle bir
lately. There
enerjisizlik var,
is no
enerji var.
behavioral problem, there is
Ağzı böyle bir salma
energy, there
anlamında.
is no
Böyle bir iştah
perception
olmadı.
pathology. The sleep
Tabii
and
birkaç ayda
appetite
devam
is fine.
edebilirsek
Academically
o çok iyi olur.
speaking,
Biraz daha
he
böyle
reads slow. There
özellikle
are
öğrencileri
certain
böyle
dysgraphic features
seçebilebilirim.
in writing.
Yani zaman
Arithmetic
kavramlarını
features
karıştırıyor.
are low. Time
Ölçekleri bakıyoruz.
concepts
İlk
are
testi müthiş. Yani
confused.
hem öğretmene
The
dair
attention
ilk isteği
deficit
bu.
is so
Diğer
good.
testisi neredeyse yok.
Hyperactivity
Karşı
doesn't
ortağıyla
exist
ortamda
at all.
sıfır düzeyinde.
And
Öğretmenin yazdığı şey şu. Sınıf içinde bir
uh,
hayal dünyasında yaşadığı dersle alakasının
the
olmadığı, ders işlenirken elinde bir obje var. Bütün ders boyunca onunla oynuyor.
the student is
Onunla oynuyor.
daydreaming,
Tüm ders boyunca
playing with
oynuyor.
an
Çalışmalar vesaire
object
gelebilir. Yani
during the whole lesson. This may get us suspicious about Asperger's syndrome. He writes the notes of the blackboard very lately. He seems not understanding the class,
üzerinden
and
1 alıyor. Barney anketinden 37 puan gibi yüksek bir puan
and
alıyor. Bu çocuğumuza yaptığımız bazı testler
and
şöyle
certain
oluyor.
tests that
Normal
we
zeka, anne sosyal
do to our
performans arasında belli
child.
bir fark var.
Uh,
Aile öğretmen
yes,
öğrenme bozukluğu
the
eksikliği listesinde
family
özellikle
in the
kesinlikle sözel alana bir
especially
öğrenme bozukluğu. BIST,
uh,
görsel iş sensorik
uh,
testinde hem işitsel hem görsel alanda düşüşler var.
there are difficulties
Skill'de
in
yol
the
montaj sorunu, kısa tikrar süresi ve Egler testinde görsel algılama motor becerilerin yaşın
uh,
gerisini saptanıyor.
uh,
Şimdi elimizdeki verileri toplayınca ne çıkıyor?
yes.
Düşük sosyoekonomik
What
düzey bir aile
do
var.
we have?
Toplumsal
The
bölge
social
çevresi
economic level
temsil
of the
ediyor. Söz
patient is
konusu
very low,
normal zeka,
and
çevre
then
diyalogları var,
it is
hiperaktivite,
normal. There
davranış
is
sorunu yok,
hyperactivity. There is no
yani
behavioral
şikayetler
problem.
temizlik, sosyal
There
kaygı
is no
olgusu
social
yok.
anxiety
Öğrenme
disorder,
güçleri veriler söz
and
konusu. Bunları da az önce belirttiğim veriler. Burada
this is the
düşünebiliriz. CDS'i
destructive diagnosis. There
ve
is
DLP
CDS, and
öğrenme
there is learning difficulty and
özellikle
attention deficit
öğrenme
disorder.
sorunu. Yaklaşımın
And
uygulaması bu olmalı.
how our approach
Öncelikle
should be,
bebeğin olduğu
first of
yeterli
all,
düzeyde
the
psiko eğitim vermemiz lazım.
parents should
Bebeğin
have
gelişimde üretkenlik bozukluğu olduğunu
enough education.
Devreye şişleri,
The
yani
ADHD
görüş, algı, taşıma,
accompanies
anlaşılma
many
farklı şekillerde farklı çeşitli öğrenme
pathologies.
derecesinde
Uh,
yani farklı özelliklerle karşımıza çıkabildiğini belirteceğiz. Öğrenme bozukluğu söz konusu olabilir. Buna müdahale edilmesi gereken bir tablo olduğunu belirtebiliriz.
there may be learning
Eşlik ettiğini,
difficulties,
kişisel potansiyelini
and
geliştirebiliriz. Aileye yönelik biraz
the
daha sosyoekonomik
cognitive
içerisinde
dissociation may exist. We can tell the problem this way: if the education level of the family is high, it may be not appropriate to use syndrome or something, because this may cause them be
Ancak çoğu
concerned a
aile ve
lot.
öğretmenler tarafından hayal
But
kurullarının tam olarak
along
takip
with the
edilmediğini
other symptoms, it may
belirtebiliriz.
not be
Yani
comprehended enough by
ilk
the
hocam
parents
belirttiği
and
gibi
the
hayal kurulları bir
teachers.
noktada çocuğun
Daydreaming
aile
is
getirmez. Daha
observed,
çok dikkat
but not
eksikliğiyle
all
getiriyor.
parents
Mesela dikkat
take
eksikliğini
their children to the
duyduğumuzda
doctor
her
because
zaman,
they are
yani çoğu
daydreaming.
zaman
The only reason,
CDS'i
main reason,
baktığımızda
is
bu
the
bozukluk
attention
durmasında
deficit.
fayda vardır.
And
O şekilde belirtmemiz gerekiyor. Şimdi ilaç tedavi
okay,
seçeneğinde
regarding the
biz
drug
öncelikle
medication
burada
treatment,
atomoksitin
and
başlattık. Atomoksitin
the
kullanımı oldu.
usage
Yani
of the
burada
atomoxetine,
4 litreye kadar
and
atomoksitin dozu
until the
yükseltildi.
age 4, the
Ancak
dose of
yeterli bir
atomoxetine
değişiklik
was
olmadı.
increased,
Yeterli
but
bir
there was
azaltma olmadı.
no enough
Sonrasında
reduction.
ise
Secondly,
metronidaz devreye girdi.
methylphenidate was
Burada
used,
7. aydan
especially
sonra
after
doz
the
artışı olduktan sonra
month 7.
döneme
After
göre
the
biraz
dosage
daha azalış
increased
eğiliminde
compared to
artış
the
olduğunu
first period, there
gözlemledik.
was increase
Bu
in the
kombinasyon
reduction level. The
CDS'i
combination
kolaylaştırmak
in terms of the
amacıyla
CDS functions
aşırı
were
toleransın
more
ilk
beneficial
etapta
in another
gerçekleştirildi. Başka vakalarda
case. Atomoxetine can
kişilerin
work,
iş
and
gelişiminden
methylphenidate
bahsettik.
can work
Şu
in
an için
yet
çok
another
önemli değil ama
case.
daha
It is
sonra
not possible for us to mention
özellikle
about a
atomoksitin
certain thing,
yerine
and
bir gidişatı
we
belirtebiliriz.
can mention
Özellikle
about a
o anne karnında
trajectory in favor
çalışanlar
of
ya
the
da sınıfta
atomoxetine.
çalışan
Looking from
arkadaşlarımızda
the
öğretmen
psychosocial
öğrenme
level,
bozukluğu da olduğu halde mutlaka
because there is
öğretmenin öz
also
eğitime yönlendirmemiz
learning
gerekiyor.
difficulty.
Okulda bu açıdan eğitsel
Uh,
tedbirler, ek düzenlemeler
Absolutely
yapılması
additional regulations
mutlaka
are necessary,
yaptırmalıyız.
and
Spor mutlaka
supportive
olması lazım
activity
her çocuğun.
is
Çünkü
necessary, and
dikkat eksikliğini sadece
the
olay dikkat eksikliği değil, yani bir
It is not only about the attention deficit, but also there is a slowness in the child, and they really see benefit of the sport as much as the medication. And these especially it is helpful to relieve the symptoms of internal looking, and also the collaboration of the school and the family is helpful to boost the confidence of the child. And the students really gets help in terms of social relations and sluggishness, inactiveness, etc. All these improve with support. And what is the level of the negative impact of CDS to the social areas? We need to determine these effectively, and there may be different psychiatric definitions. Does it correspond to it? We should observe it if there is such a trajectory, and we should make other psychiatric interventions. Especially here, it is believed that there is a correlation. What are the outstanding issues in this case? When the case was brought firstly to the doctor, the attention deficit and academic problems were explained by the parent. It may be not observed, just not noticed, and the autism spectrum disorder also has it, and people only bring their child to the doctor when there's an attention deficit, and CDS accompanies autism spectrum disorder also. And also there is even a study about correlation between CDS and smoke addiction. Yes, ADHD is related, but it is not observed only in ADHD. There are the comorbidities accompanying CDS, ADHD, etc., moderate social anxiety findings, etc. And the case benefits from the combination of methylphenidate and atomoxetine. The atomoxetine should be kept in mind. There is no certain algorithm yet. Let me finally state this. How is the trajectory? How is the trajectory? And I made the graphics myself here. In parallel with the age, as you know, hyperactivity reduces, impulsivity reduces, but attention deficit is persistent. It decreases only minimally. The treatment lasts longer, but when it comes to cognitive dissociation, there is increase along with the age. It means the depressive symptoms increase along with the age. When you go towards adolescence, a slight increase happens. So how can we take all of them and distinguish them? This is very hard, especially depressive features and CGT. It is very critical for you to make these two distinctions. Let me conclude with it is frequently seen with ADHD. It is accepted as a syndrome. Is it a different disorder or not? And it should be recognized well and explained well to the families. Um, uh, It may reduce academic success. There is need for interventions. Thank you so much for your patience.
Yapabildin mi? Hamura şey yok senin.
Hello, first of all, I would like to mention about something. Many years ago, we saw this case in a motor accident, traffic accident. The child couldn't escape from motor. It was very in line with CDS. Then we investigated there was an overlook metabolic disturbance, but the diagnosis took 1.5 years. There was a metabolic disorder just appearing like CDS. In your viscous test, in your first studies, the total IQ is normal, but in your own study, in the performance or in the verbal skills, did you observe any meaningful difference? What did you ask? In the performance and verbal sub-tests, was there any score difference? There was no in the total IQ. In our study, there we had two separate groups, ADHD group and learning difficulty groups. Yes, there was difference in the total IQ and in the general score. And likewise, in the verbal and performance IQs, it was lower than the ÖYB group. But then we controlled this difference between these groups and the intelligence level. And before putting this diagnosis in routine practice, should we require through tests? And when the parents say that the child is daydreaming, what should we do? What should our approach be? In the clinical practice, this is something that we come across. We suspected of the existence of an underlying neurological problems, and therefore we referred them to the child neurology. Absolutely, this should be kept in mind. We made a new study. It was published, especially the daydreaming, etc. These seizures of absences are confused with each other. These symptoms turn high. In those with abscess, this doesn't come out as so high, but it is high in those with CDS. I mean, these are very independent from each other, but they may be confused with each other. The past neurological family history is very important to consider. Is there any psychiatric inclination, disorder, etc.? We should take into consideration all of these before just jumping into the conclusion that there is absence. And the hypothyroidism may come to the find. You should check it to be on the safe side. Okay. Actually, in the literature, there are about 300 publications in Turkey. This disease is the most common in the literature. And 9 studies belong to our university. Thyroid function tests and absence seizures. Clinically, diagnosis is put well, but I think we did it because it was good for academic purposes. It is very important to exclude Asperger's syndrome. If they meet the criteria for Asperger's, we should absolutely check CDS symptoms because they imitate each other. And also, let me tell this, in daily practice, if the person that you see visually and their intelligence tests are not compliant with each other, CDS should come to your mind. You should be suspicious of CDS.